Everybody. On behalf of Oxy and the Endometriosis Committee of Oxy and the Endometriosis Society India, I welcome you all to this webinar on adolescent endometriosis, which is a lecture series. So we have decided that we will take one particular topic and cover all the aspects of endometriosis so that it will be an in-depth analysis, and we have decided the people who are really proficient in this particular specialty would be our expert speakers, for which we have Dr. Manjula Anagani today to address on adolescent endometriosis. So it is my pleasure to welcome you all to this important session on adolescent endometriosis, which is a condition that continues to challenge the clinicians because of its early onset, subtle presentation, and the long-term implications that it causes on the reproductive and the psychological health. So we all know adolescent often suffers for years even before receiving any proper diagnosis, because many a times there will be a delay in diagnosis and their pain is frequently dismissed as abdominal cramps. And this makes our as clinicians even more critical, because to recognize the early red flags, and also we have to diagnose, close the diagnostic gap, and also offer a timely evidence-based interventions. So, in today's session, we aim to unpack these complexities with the help of our distinguished speaker, who will guide us through the latest insights in the diagnosis, the medical therapy, surgical considerations, and the long-term care. So, as a moderator and the convener, I invite you all to reflect on how we can better support our younger patients, not only medically, but also emotionally and socially, ensuring that they have access to a very compassionate and a multidisciplinary care from the very first consultations. So, with that, let us begin this. I too welcome our President of Oxy, Dr. Sampath Kumari, Madam, also for the welcome address. Before which we will start with the traditional Oxy prayer. So thank you, God. In humility, we gather. In gratitude, we pray for all the good things you have given us, and shower us with your blessings to pass on the healing touch to celebrate the arrival of each new life on Mom Reborn, the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. See, we bow before your kindness and the magnanimity of your endless love. So, Dr. Sampath Kumari, Madam, I think she is busy, so she'll join a little later. So, we seek the blessing of the Almighty Ma Saraswati to make sure that this lecture series goes without any hitches. And along with me, we have Dr. Ramani Devi Mandam, who is also the convener for this particular lecture series. This is me, and Madam, as we all know, was the past chairperson of Endometriosis Committee of Foxy. So she is the the authority when it comes to endometriosis. So I have included Ramani Devi Madam also in this webinar, because she is such a knowledgeable person when it comes to endometriosis. Madam is also the director of Janani Fertility Center and past vice president of Foxy and associate member of RCOG, and also governing council member of ICOG. She was also the president of TNFOG 2024. And of course, her area of interest is endoscopy, high risk obstetrics, endometriosis, infertility, and ART. So we also have our chairpersons, Dr. Victoria Johnston and Dr. Vijaya. And Dr. Victoria is currently the Vice President of Trichy Obstetrics and Gynec Society. And also she was the past Secretary of Trichy and Trichy OBG and the member of the Scientific Committee of Trichy. And she is a consultant in Janet Nursing Home, Trichy. And Dr. Vijaya is the HOD and professor of ESI Medical College, the past president of Oxy, and a member of Oxy Medical Education Committee. Then we have, before that, we also have our expert speaker, Dr. Asha Rao, Madam, who is also was the past chairperson of Oxy Endometriosis Committee and director of the Rao Hospital. And also she has various accolades and also have various publications and research. And she was also the past president of Coimbatore Obstetrics and Gynec Society. So now I'd also like to welcome our chairpersons, Dr. Victoria and Dr. Vijaya, madam, to introduce our speaker, Dr. Manjula Anagani, and also invite our expert, Dr. Asha Rao, madam, to join this session and give her expert opinion at the end of this session. So over to Dr. Victoria and Dr. Vijaya, madam, to take forward the session by introducing the speaker.
Victoria, you can very good evening to one and all gathered here. It's indeed my great pleasure to be here as a chairperson in this extremely interesting session. I thank the Oxy and the ESI Society for giving me this opportunity, particularly Dr. Mala Raj for this opportunity. It is my great pleasure to welcome our expert speaker, Dr. Manjula Anagani. She's a consultant OBGYN, laparoscopic and robotic surgeon, an esteemed urogynecologist. Currently, she's the clinical director and HOD of the CARE Vatsalya Women and Child Institute, the CARE Hospitals, Hyderabad. Madam is the founder secretary of the IAGE in Telangana and the founder secretary of the Society of Ovarian Rejuvenation. She has a great distinctions to her credit. She holds the Guinness record for an interesting achievement of removing the most number of fibroids in a single patient. And Madam is also the proud recipient of the Padma Shri Award. Indeed, a great honor, Madam. Congratulations. Way back in 2015.
Yes.
Welcome you, Madam, to speak on this interesting topic.
Thank you, Dr. Victoria. Thank you for the kind words, and thank you, Dr. Vijaya, for chairing this session. And I'd like to thank Oxy and Dr. Mala and Dr. Ramani for giving me this opportunity. Welcome, Dr. Ashaf. Replace current share. Yes, allow. Only one person. Yes. I'm sharing my slide.
Hi, Manjula. Hi, Mala.
Hi.
Asha ma'am, good evening. Good evening. Welcome.
Good evening. Yeah, I was a little late.
So right on time, Dr. Asha.
Thank you.
Madam is
Hi,
always
Dr.
on time. Yeah.
Vijaya and
So I'm going to.
Hello.
I hope you are seeing the slides. I just hope. Right.
Yes, you can see the
Yes.
Today, I think, like Dr. Mala said, the reason we have this topic is this is the age group when patients usually don't know whether to go to the pediatrician, who doesn't know about the endometriosis, and to whether to go to the gynecologist, because a gynecologist is supposed to be a doctor for parents, for mothers, for who want to become pregnant, and not for young girls. So, and they also have this thing that gynecologists, if you go, they start putting them on hormones, so they don't want. They think that we put them on OC pills, so they do not want to go it. But what is endometriosis in adolescents? Historically, we have always thought that endometriosis is a disease which affects the adult woman, but recently it is increasingly being diagnosed in the adolescent population. Pain may start at a young age, even before the onset of menstruation. That is what we need to understand. Everything starts from adrenarche. The whole hormonal insult starts from adrenarche. So even before thelarche or just after thelarche, even before menarche, the pain starts with endometriosis. So high degree of suspicion is needed. So when you have the adrenarche, thelarche, pubarche, and then menarche, please remember a girl with just thelarche, no menarche, can still be having an endometriosis. This high degree of suspicion is needed. And diagnosis is usually very delayed for several years, on an average about 9.8 years. The girl is suffering for so many years. By that time, the destructive lesions should have affected the tumor structures, severely compromising the fecundability. Incidence varies because, like we all do, we do the work, but we do not publish. So it is and the diagnosis only is made on when they do the laparoscopy for chronic pain, the incidence is somewhere between 19% to 73%. So Goldenstein says that if an adolescent comes with pain, it is 1:2 ratio of it being endometriosis. And if the patient is not responding to NSAIDs or hormonal treatment, then the incidence goes up to 70%. So Endometriosis Association says 66% of adult women are going to have this onset of symptoms before the age of 20 years. Doesn't these statistics make us very scary? It's only going to increase because of EDCs. So this is a stupendous incidence. Think that 50 to 75% of adolescent people who are having pain, especially pain which is not coming down with simple NSAIDs, is definitely endometriosis is what we are dealing with. So mean age of diagnosis is around 18 plus 1 or 1.8 years. Age of symptoms is less, and the number of docs needed to diagnose is on average 4.2. But it might take to 7 to 8 doctors to diagnose endometriosis by the time they come to us. It can be a pediatrician, pediatric surgeon, urologist, and neurologist, and a gastroenterologist, and so on. The risk factors, who are the people who are going to have this at adolescent ages? Uterine tract anomaly. Any kid who is having uterine tract anomaly has a higher incidence of endometriosis, and chronic pelvic pain at the onset of time of menarche will have again higher incidence of this endometriosis. Menarche at an early age is directly correlated to the increased incidence of endometriosis. So when we take Mullerian anomalies into consideration, the incidence varies between 7% to 40%. Early onset is one thing, especially if outflow obstruction is seen, that is 16.2 years versus 19 years. Ovaries are involved in these cases in 93.3%. So if associated Mullerian anomalies are there, the chances of the ovaries getting affected, not just the DIE, is almost as high as 93.3%. Rectovaginal pouch or uterosacrals originally were thought to be only 13%. In the recent times, now it has increased to 25%. So economic burden is hospital length of stay has come down since more and more laparoscopic surgeries and the medical management has started, but per patient cost increased by 61% because of the medical management, again because of surgical management, which has increased in the overall. To put it in a nutshell, it is a chronic inflammatory estrogen-dependent disease, often begins in adolescence, symptoms frequently dismissed. Early detection prevents the progression and preserves fertility. This is the reason why we need to understand what adolescent endometriosis is and why we need to keep it under control. The impact of this adolescent endometriosis is deadly. It causes severe dysmenorrhea in teens, leads to absenteeism, reduced quality of life, mental health impact, anxiety, depression, sometimes suicidal tendencies also. Coming to the clinical approach, what do we feel? What is a general practice approach? This is it. We are like, why do we have to see this kid? A mother comes who is more nagging. A girl comes who will be looking down, might not answer properly, and she's a rebel. She is like, why me? I don't want to listen to you. You want to give me medicines? I will not take it. You tell me whatever you tell me, I'm not going to listen to it. And this mother who is so inquisitive will keep on asking questions. It's like they want us to teach them ABC. When we tell them, please go Google and come back and then we will discuss about it. No, they don't want. You're a doctor. You're supposed to tell me. So you should tell me. So they want us to teach endometriosis ABC. And next comes, why my daughter? Why did she get it? Third is, you want to give hormones to her? No. Fourth is, you want to do surgery? I don't want my daughter to be having surgery. How are you sure that it is endometriosis? CA125 can be increased in so many things. So without diagnosis, why are you putting us on these medicines? These are the things which we are going to see. And we are like, hope they go to somebody else. So let us first ask ourselves a few questions. What do we actually know about endometriosis, and is there a difference between teenage and adult endometriosis? Is the treatment always required for a teenage adolescent endometriosis? Who needs treatment? And does any treatment really work? And are the strategies different for adolescent and adult endometriosis? And does early treatment in young women prevent infertility and progression? Latest management options, how long to take? When the attendant is going to ask, you mean to say that my daughter has to continue for 5 years, 6 years? What are the side effects of these medicines? Do they prefer to have the medicine and live with it, the disease rather than the medicine? And what are the future directions for adolescent endometriosis? So let's take it one step out a second. What do we know about endometriosis? We know simply that endometriosis is a progressive disease. It is like cancer, but not cancer. It's a locally invasive and destructive disease. Is there spontaneous regression? It's a question mark. There are occasional reports that, yes, we have seen endometriosis which has regressed because of a lifestyle change, whatever, etc., etc. But that's the biggest question mark. What is the natural history? Nobody knows. Will it be staying stagnant? Will it worsen? And which are the patient it's going to be worsened? And what is the lifestyle changes which will make it stagnant? Again, it's the biggest nobody knows question. But however, we also know that medical treatments and surgery fail to arrest the disease. It will not stop it. Combination of treatments also fail to give that cure, only it suppresses. So it's always about suppression or relapse and the remission we talk about. And pregnancy has a variable effect. It is like in olden days, we used to say, a person is mad, get them married, the madness will go. The same way, endometriosis, let them have a child, and the endometriosis will be suppressed. That cannot be the truth anymore. So it has a variable effect. And after delivery, again, we look at putting the Mirinas to suppress the disease. So the suppression of the disease continues. These are a few things we know about endometriosis. What is the difference between teenage and adult endometriosis? Let us understand that. So presentation is usually pain rather than infertility. They come to us either with chronic pelvic pain or GI pain or urinary symptoms. And mother with endometriosis is the one who brings their daughters, and they are the pain in the dash. So they get us for the evaluation and early diagnosis. They refuse to accept whatever we tell, and severe dysmenorrhea, which is unresponsive to NSAIDs and COCs, is what we see with these adolescent girls. And the school absence, fatigue, mood issues is what we see. Characteristics, we have two relevant variables: menstruation in general and the BMI. So what are these variables? Early menstruation, they'll have a higher incidence of endometriosis. In contrast, for adult women, an inverse association is there with the risk of suffering. The thinner girls will have a higher incidence of endometriosis and obstruction. So this is what is the difference between adolescent and obese. In adolescent, obesity lead to PCOS, so anovulation, and these are the things which will lead to lesser endometriosis rather than more endometriosis. Thin girls, BMI, will have more incidence of endometriosis. Common symptoms would be acquired or progressive dysmenorrhea in as high as 94%, and what we see is the red lesions, which are active producers of prostaglandins. Acyclic pain is seen as high as 91%. Dyspareunia is seen in almost 2 to 46% in a teenage girls who have intercourse. Gastrointestinal symptoms is again 2 to 46, but mostly acyclic and cyclic pain in 62.6%. So what are the morphological features differentiation which we used to see before, and what are the recent changes which we have seen? Several authors from last decades before has to say that there will be higher incidence of subtle, clear, red or vesicular implants, and very rarely DIE. But in the recent thing, like I said, 25 to 30% adolescent kids, we do see DIE and severe stages, which is ovarian endometriomas along with extensive adhesions. It's no longer a disease of subtle superficial lesions in the last 1.5 decade. So infiltrating endometriosis, which goes beyond 3 to 5 mm, is increasing, and there is also associated peritoneal pockets with endometriosis in 17% of these adolescent kids. So it seems that once the adolescent reaches the ages of 16 years, a risk of severe endometriosis needs to be taken into account. In 12 years, 11 years, it usually might be superficial, but once they cross 16 years, it is a severe endometriosis. So diagnosis is very important, because prompt diagnosis and adequate therapy will suppress the disease, and it is needed to return to normal psychosocial development and self-esteem, and it also improves the scholastic performance, leading to normal activities. So what we need to differentiate them is appendicitis, PID, Mullerian anomalies or outflow obstruction, bowel diseases like any Meckel's diverticulum, hernia, musculoskeletal disorders, and psychosocial complaints also. So diagnosis, how difficult or easy is to diagnose? Very difficult to diagnose, because whatever we see is high degree of suspicion is needed, and when we say something, there is a refusal from the parent to accept, and the girl doesn't know what to do, listen to her mother or to the doctor. Aim is to rule out pelvic mass or congenital anomaly. So if there is an anomaly, yes, it's easier. If there is an endometrioma and the scan tells it, it is easier. But otherwise, pelvic examination is difficult, especially in women. In girls who have not had vaginal intercourse, then we are looking at rectal and abdominal examination in dorsal lithotomy, which is little discomfort for the girl, or a cotton-tipped swab to evaluate the presence of a transverse vaginal septum or agenesis of lower vagina. Ultrasound examination is helpful in evaluation of pelvis of young adolescents who decline a bimanual or a rectal abdominal. This becomes the first stay in India, because ultrasound is much more cheaper and much more easily amenable to be getting it done in India than in Western world. So it's ultrasonography and MRI, which will evaluate the anatomical structures, and not specific as an adolescent, will rarely have a pelvic mass from the endometrioma or uterosacral nodularity. It's seen in about 25 to 30% only. Rest of the people, it is usually the superficial but active lesions. CA125 is very sensitive but not specific. It has its own falsettos, like second day and all, it might be a little high. But what I wanted to tell here is a little bad experience which I had in the recent times, which should be a learning lesson for the other gynecologists who are treating before telling the patient attendants that no, your daughter does not have endometriosis. We do not diagnose endometriosis based on CA125, but we do it just to have a baseline when we start treatment. No, I had this young girl who had this congestive dysmenorrhea who came about with that when the mother who came. We did a CA125. Unfortunately, it is done during periods, so it can be little high. But that was not the reason for which we diagnosed. It came as 55, but we never gave importance to that per se. Clinically diagnosed as endometriosis, and we started medical management diagnosis, and we said she has to continue. And she wanted me to explain to her ABC, and I, as usual, I said, please go Google and come back, and then we can discuss. So her ego got hurt that I told her to read and come. So she went to another hospital where the gynecologist said, oh, your daughter does not have endometriosis at all because CA125 is done during periods, and she just have pain during periods. You can take this thing. Now, by this negligence of not diagnosing endometriosis in a very young age group, and that girl will be going ahead to go into a severe endometriosis later on. So I think before negating the other doctor's diagnosis, please take into consideration in whole of every symptom the girl says, and then start her treatment very early. TV hydro laparoscopy, which was done in certain countries, are not widely used. Laparoscopy is selective cases, in only refractory cases which are not responding to medical management and when we need to know the diagnosis. The next comes the question, is treatment always required to these, and who needs the treatment? Empiric ACOG 2005. This starts from that. Let me go step by step with every guideline which says till 2022 guidelines of ESHRE. In ACOG committee right back in 2005, which holds true till today, has said that empiric treatment should be initiated in adolescent. See, don't listen to the attendants and start giving only NSAIDs, and not starting the conservative management to suppress the disease and keeping the disease under control. And treatment should focus on conservative measures with only medical or even surgical, but now it's only medical in 2022. Only procedures that preserve fertility options should be applied, and long-term endometriosis treatment should be required for chronic pelvic relief. And because there is no cure, long-term treatment should continue until desired family size is reached or fertility is no longer needed. Now, this holds true even till today. We start the medical management in a 15-year-old, 16-year-old. We tell them you need to continue till she thinks of pregnancy and pregnancy is over. So it might be for 10 years or 15 years or 20 years. We are not. That is something we need to inculcate into the minds of the girl and the parent. She has to be under doctor's supervision every 6 weeks, 6 months with an ultrasound and a CA125. And we analyze the medical management and the side effects of it, and then continue for another 6 months and continue for another 6 months. These are golden pearls even till today. Next came the ESHRE guidelines 2013, which said that endometriosis is identified at lab. If it is identified at lab for pain, you should treat it. That is see and treat holds true. But if the laparoscopy is done for asymptomatic endometriosis, then we should not routinely perform any excision. I believe a lot in see and treat because it is a progressive disease, and even though natural course is not known, most of the time it is progressive. So, but ESHRE good practice guideline is, because natural course is not known, incidental finding in asymptomatic endometriosis, we should not be doing anything. But if it is done for pain, see and treat holds true. And it also, GPP also says clinicians should fully inform and counsel the woman about any incidental finding of endometriosis before the surgery and take consent and then do it. So the premise for treating the asymptomatic adolescent is endometriosis is usually a progressive disease without a known cure. So even if the girl is asymptomatic and you see endometriosis when the girl is being operated for appendicitis, you should put her on medical management after that because it is a progressive disease. I hope I'm making it clear and I'm being emphatic about certain points, which is very important about it. Now, then coming to 2022 ESHRE guidelines, pain is the main thing. The different options is depending on the decision making making and decision sharing we should be discussing. NSAIDs is first line, then hormone treatment is the first line we we need to do, then surgery should be offered as an option if it is refractory to the medical management, or if there is an endometrioma, or it is progressing in size and location. So medical management option considers depends on combined nocipils, progestogens, GnRH analogs, GnRH antagonists, and aromatase inhibitors as a third line. So we have first line, which is NSAIDs, combined hormone pills, progestogens, and second line as agonists and antagonists, third line as aromatase inhibitor. We'll go step by step. Then comes the guidelines by the NICE, ASHRAE, WAS guidelines, which says that the treatment should be tailored to individual patient needs. So initial management should involve hormonal treatment, whether it is progestogens or oral contraceptive pills. At such an early age, I believe in starting progestogens rather than oral contraceptive pills, because the side effects because of estrogen is real and it is high. And today's times, more and more patients are having migraine, and we do not want any thrombogenic action. So first line comes hormonal. The second line comes hormonal alternatives, that is GnRH agonist or surgery after that. And if the rather than the surgery, medical management should be the first line. So no pelvic pain, nothing to be done, expected management and medical management, even if it is asymptomatic and we do know the disease is there. If there is pelvic pain, long-term medical management should be thought of. And if there is pain is worsening, then do the surgery. And then again, post-operative medical management till she thinks of pregnancy. So post-operative hormonal medical therapy is beneficial in terms of pain, disease recurrence, and pregnancy. So at 12 months or less, if the medical manager decreases the pain recurrence, disease recurrence at the 1 year is also less, and pregnancy rate is higher. So post-surgery also medical management is given for long-term. So third point we look at is how to avoid recurrence management and prevention. Although the definition of recurrence lacks uniformity, recurrence means symptom relapse, absence of improvement in infertility, and revisualization of lesions with imaging or with surgery. So symptom and lesion recurrences frequent without the use of post-operative adjuvant therapy as high as 50%. Therefore, the post-operative, again, the medical management should continue till the girl finishes her pregnancy. About 50% needs analgesic and or hormonal therapy within 2 years after surgery. And after first-line surgery, if you're doing the first surgery as a first line, pain symptoms and endometriosis recurrence should be limited by using the progestin or contraceptive. So there is a paradigm shift in endometriosis management. Originally, current temperature right now, we do a diagnosis. If immediately you do a first surgery, if necessary, then we do post-operative medical management. And then, if necessary, repetitive surgery or ART as the girl becomes older. But now, what are we doing? 3 modern management options. First, non-surgical diagnosis. We don't have to look at high degree of suspicion is needed. Then long-term medical management is the first line of management. Then, if necessary, single complete conservative surgery followed by ART treatment, and again, long-term medical management. Second option we have is again non-surgical diagnosis of endometriosis, long-term medical management, no surgery, treat for ART, and again long-term medical management. Means surgery is completely avoided. So if this is possible only if the girl is on medical management right from adolescent age group, we can totally avoid the surgery. The third one would be non-surgical diagnosis, long-term medical management, ART, long-term medical management, and a final complete conservative surgery. The surgery either becomes the pre-pregnancy surgery or after the long term when she's still suffering with the medical management. So these are the 3 modern management options which we have, which we need to follow in today's time. So does any treatment really work, and are the strategies different? So there is no permanent cure for endometriosis. So aims of treatment would be to reduce lesions, avoid recurrence, and alleviate pain and other symptoms, maintain and restore fertility, improve the quality of life of the adolescent, and reduce the number of unnecessary surgeries and prevent future surgeries. That's where we are in. So overall approach of treatment would be to recognize the goal. Are we dealing with pain or fertility even if she's an adolescent girl? And we are looking at pain in adolescents. Consider the disease factors, that is, it is a progressive disease and it's a locally invasive disease. Patient factors, is she going to listen to us when we give the medical management, or does she have other comorbidities like hypothyroidism or any other hormonal imbalances, or does she have other autoimmune diseases which can worsen this disease? Discuss with the patient that it is a chronic disease and there's no role of nothing called cure. Optimal treatment is unproven or non-existent, but near optimal treatment is now done with medical management and the surgery when needed. Appropriate therapy would be multidisciplinary approach and pain clinic and counseling. So treatment modalities will be expectant, empiric, medical, and surgical. So where do we do expectant treatment? Asymptomatic treatment with surgical diagnosis, according to Ashray, should be expectant management. But according to most of us, even if they're asymptomatic patients with surgical diagnosis, to prevent as the disease is progressive, we should be giving them the medical management. Suspected disease, but without a surgical diagnosis, and the girl or the parent refuses to take the medical management, again, role of expectant management and allow it to progress and then start the treatment. Empiric therapy, younger than the adolescent is usually divided into 18 and less and 18 and above. That is teenage. I have mixed adolescent with teenage because till 18 years we look at adolescent. Now, why is it divided? Because 18 years is the highest of the estrogen developmental growth, and the girl also attains adequate maturity to her to understand what we have to do. And the bone demineralization is of significance below this age because the maximum height is attained by this age. So younger than 18 years, combination hormone therapy and NSAIDs is what we look at. And more than 18 years, we can give empirical trial of GnRH agonist to have a diagnosis. What is therapeutic trial? We give GnRH agonist or antagonist therapy for at least 2 cycles or more than a cycle. And if the pain comes down, that means she's having endometriosis. So if we don't have any other way to diagnose, I think this is the best way to diagnose. Give her a COC continuous or a GnRH agonist or antagonist therapy. And if the pain comes down, that means she's having endometriosis. And COCs if they're younger than 18 years. For patients less than 18 years, we would decline empiric therapy because of the effects of GnRH medications on bone formation and long-term bone density. Then we can do a laparoscopy and diagnostic. So if we have a very adamant parent who says, like, unless you diagnose, I won't give my daughter this thing, and we need confirmation, we go ahead and do this. And during confirmation, what we do, we'll tell you. This is the thing which we follow till today. Little change in medical management, but this is the protocol for evaluation and treatment of adolescent pelvic pain with endometriosis. I hope you are seeing this. This is the one which is published in 1995, Adolescents and Endometriosis chapter, and even today it holds true. Take a proper pain history, start them on continuous combined pills and NSAIDs. If pain still persists, then start GnRH agonist if the girl is more than 18 years. And if improved, it means that she's having endometriosis. I hope I'm making it myself very clear. Then if it is persistent pain and she's not more than 18 years and they want a confirmation of diagnosis, then do laparoscopy and confirm the visualization of the thing and take the biopsy and do the surgical treatment of ablation or resection or laser. Now it is resection of endometriosis. And if there is no endometriosis, which is visually histologically negative, CD10 is also negative, then send the girl to gastrointestinal or urological evaluation for sprue and all those diseases and pain management service. But if endometriosis is visualized or by pathology less than 16 or 18 years, it is continuous combined hormonal therapy. And if it's more than 16 years and the symptoms persist with continuous combined hormone therapy, we should add GnRH agonist or antagonist now, or again continuous combined therapy. If there is no pain, still continue. If there's continued pain, then do laparoscopy, excision, again continue medical management. Till when? Till her pregnancy is done with. So different types of medical management are currently available for endometriosis. Like I said, NSAIDs, they act as analgesics by inhibiting the prostaglandins. They also act on local cytokinins within the endometriotic deposits. The evidence is it's effective for primary dysmenorrhea, but inconclusive evidence for effectiveness in endometriosis as well, because it's a congestive dysmenorrhea. The progestins become the first line of medication, and there are multiple modes of action, mechanism of action, and they reduces the pain by 64 to 100% and as similar effectiveness as generic agonists with fewer adverse side effects. And metroxy is useless, so it is no longer used. It is dydrogesterone and dynogest, which are the first line of medication. I'll go through some more slides about it, and so you can understand how you want to start and how you want to give it. Generic agonists, they block the ovarian estrogen production and induce a temporary menopause-like state and more effective than placebo for endometriosis-associated pain. Generic antagonists, that is, in India, we have elagolix and relugolix. They block the generic receptors to suppress gonadotropin, the symptomatic relief and regression of endometrial implants. We will talk about each one in one slide later on. The combined OC pills will reduce the menstrual flow and cause desudilization and reduce the incidence of endometriosis, similarly effective, but less effective for dysmenorrhea, and also side effect profile is little high. So it comes low in my thing. So in a nutshell, if I put medical management, first line is NSAIDs and continuous combined therapy for at least 9 to 12 months, but then continue it till she wants pregnancy is over. Progestins, least effective is medroxy, not advisable. Depo-provera is again least well tolerated. US FDA warns against it for mineralization. Mirena, US FDA do not approve. Cochrane suggests can be tried. I have put a Mirena for even an 8-year-old kid. So don't worry about the only thing is under anesthesia. ACOG supports the use in adolescent, and we can go for, because in that age group, why did I say that in an 8-year-old kid I put, they're very reluctant and non-compliant for medical management. So under anesthesia, putting a Mirena will decrease their pain and the flow. And because it is superficial endometriosis in those ages, they respond very well when we put Mirena at that age group. One of the kids who I have put, I have a video of hers, I will show you. Then I will talk about it. So dynogest dose is 2 milligrams once a day, dydrogesterone 20 milligrams per day, continued continuously for 7 years, 8 years. I have an experience of using more than 12 years as of today. So second line is generic agonist, not offered as a first-line therapy for adults less than 16 years, limited to 6 months due to profound hypoestrogenemia and effect on bone realization. Now we have generic agonist with add-back therapies. No data exists in the long-term effects, so reserved for adolescents refractory to continuous combined therapy to 2 years of usage. Lifestyle modifications like adequate physical exercise and calcium, vitamin D are also essential to maintaining the proper bone health when taking generic agonists. Danazol, not advised. Aromatase inhibitors, no data. So we stick to only these things. So what is the optimal medical management goals? Partial suppression of E2 within the range of 30 to 60 picograms. I want you all to remember this 30 because that is where the medical dosages for the kids, we need to decide how much to give so that E2 will be within the range of 30 to 60, the range which will optimal compromise between the efficacy, tolerance, and safety. So improvement in symptoms, mainly pain resulting in inflammatory endometrial lesions should be the main goal. So hormonal treatment, first line, like I said, is OC pills, progestogen, but brought us some side effects like both venous and arterial embolism. I have seen a young girl coming for amputation of the arm because OC pills were given. So limited long-term efficacy if I want to give it for 10 years or anything like that. So due to progesterone resistance, 33% become poor responders. So SPRMs induce progesterone modulator associated PAACs and ectopic foci, and their efficacy is limited. So ulipristal and all is now what we don't use. Progestogens have multiple mechanisms. They can act proliferative activity on the endometrium and decrease the proliferation, inhibits the inflammatory pathways, also induces apoptosis in endometriotic cells. So it acts best therapeutic effect. So many treatment regimens are there which use progestogens. What is thing is dydrogesterone and dynogest. Eschrei recommends it as a first line of treatment. The use of progestogens and antiprogestogens as one option to reduce the pain. The adverse effect profiles also should be taken into account, especially the thrombosis and androgenic effects. And to consider prescribing the Mirena or levonorgestrel to reduce the endometriosis associated pain is important. So second line will be GnRH agonist, that is both leuprolin, gosylin, triptorelin, because delayed therapeutic effect will be there because of flare-up as effect, and ovarian cysts can again develop. Excessive suppression will be there to less than 20, so side effects profile is very, very high because of the hypoestrogenic adverse effect. Inability to titrate the E2 levels because we cannot titrate them once the injection is given. This oral medication, if we get, we can titrate the dosage accordingly. And the oral, the reason why I'm talking about is the latest elagolix and the relugolix which we have, because they are all the second line and they are the antagonists. The E2 is maintained between 30 to 60, and the hypoestrogenic phase is less, and unpredictable reversibility of treatment because of the injectable Depo-Provera, especially in the young kids. We prefer to give once in 3 months, and the 3 months she has to bear the side effects. So treatment duration is limited by flare-ups, hypoestrogenic adverse effects, including the hot flushes and BMD loss. So then comes antagonist, that is the ideal new option, which we started using from the last 6 to 8 months. I think 8 months before we started using elagolix, and relugolix from last 3 months. So oral GnRH antagonists are short-acting treatments for endometriosis-associated pain. They stop the receptors at the level of GnRH antagonists at the pituitary gland, also at the level of the uterus, and also at the level of ovary, where it inhibits FSH, LH. So it rapidly suppresses the LH, FSH. There is no flare-up and direct obstruction of the receptor. So it is immediate, and it is oral. It is the flexibility which is there with the dosages, where it can be with elagolix 150 or 200. 150 BD is what I usually use. It can be 200 OD also if you want to give it for longer duration. I give it immediately for an adolescent if necessary, 150 BD for 3 months, then change over to Dynogest or dydrogesterone, or elagolix plus Mirena, and continue with Mirena after 3 months. So if I have to give elagolix, it is 40 milligrams OD for 2 months, 2 years. So competitive blockage of GnRH receptor, dose-dependent suppression of FSH, LH, inhibition secretion of ovarian steroid hormones. Why did it say dose-dependent suppression of FSH, LH? That is the reason elagolix is never, and relugolix people do not tell that it is a contraception. Additional contraception like condoms should be used along with them. So immediate GnRH suppression, dose dependent, like I said, and rapid reversibility. And immediately after you stop it, within next month or the next month, when they want pregnancy, they can become pregnant. Possibility of individual dose tailoring is what we look at. So estrogen suppression decreases the endometriotic lesion, atrophy, progesterone suppression will atrophy the ectopic endometrium, and also promotes the apoptosis, and inflammation is decreased. So this dual expression is what is important. We have elagolix, relugolix, linzagolix, and ASP 1707, but in India, as of today, we have elagolix and relugolix. It has been approved by endometriosis by FDA. So as of now, the other two, there is an ongoing clinical trials with lesser side effects is what we hear. So elagolix is orally administered, and US FDA approved for endometriosis, 150 and 200. We can give 150 OD up to 2 years or 200 BD up to 6 months. In India, I think Indian women respond more than in the Western women because of the steroid pathway of progesterone, our hypercholesterolemia, which we have. So we in India have a good effect even with 150 BD for about 3 to 6 months. Then you have contraindication similar to that of the uniprestal severe hepatic impairment, where they can be limited to 150 OD for 6 months, especially in a child. It is not influenced by body weight or BMI or presence of renal impairment, but by hepatic impairment. So it is initially immediate relief. Symptomatic improvement is seen within 4 weeks. An oral agent with short half-life, and it allows us to have individualization of treatment and does not suppress the normal endometrium and does not completely suppress ovulation. Remember that. So use contraception. Relugolix is the drug of choice in adolescent women, girls, because we can use it for almost 2 years, and it's an oral non-peptide, and it has the additional ocipil in it with the lowest dose of estradiol of 1 milligram and norethindrone of 0.5 milligram. So the side effect profile is very, very less. 40 milligram OD is what we use. This is the way it works, and 1 tablet orally once daily for 24 months. So efficacy summary says that both are very good. Only thing is BMD is much decreased, much better BMDs are seen with relugolix than with elagolix. So this is the HDA guideline, which says laparoscopy is no longer needed. We have to be starting with antagonists and the agonists. So let us come to the surgical management. We have variety of treatments which have been told, but indication of surgery in adolescent is severe incapacitating pain symptoms with severe functional impairment. When we have a concern regarding Mullerian anomalies, severe distortion of anatomy, failure of expectant or medical management, non-compliance with intolerance, and if there is an endometriosis emergency. So when when we need a diagnosis, that's when we do it, or when the findings show they are the gold standard. At the time of surgical diagnosis, in 60 to 80% in adolescent, when we do, it is in the stage 1. But later, when we do a surgery for adolescent-related pain, what we see is most commonly we see the disease is located in the cul-de-sac, like I said, peritoneal pockets, and it is atypical in appearance, and radical procedures should be avoided in this age group. If there is an associated Mullerian anomaly and outflow tract obstruction, and once you separate these obstruction, regression of disease is quite common. So with severe endometriosis, surgical treatment preceded by 3-month course of medical treatment, and then followed by medical treatment till she becomes pregnant is what we should be looking at. Optimal surgery is removal of all visible lesions, more beneficial endometriosis in severe disease rather than a mild disease. Second look, laparoscopic conservative treatment will actually help a lot compared to laparotomy, and only procedures that preserve fertility is what we look. This is an adolescent girl, like I said, which I put a Marina at the end of the procedure. She is a daughter of, she's now a gynecologist, and I delivered her recently. She is a daughter of a general surgeon. She suffered with pain. Everything looked fine here, but when we see this is the superficial lesions where we see everywhere anything. So this is where we do a butterfly peritoneectomy, remove the whole thing, and the confirmation of the diagnosis is done by sending it for CD10 marker, which will tell whether the endometriotic stroma is positive or not. So you will not see endometriotic glands there, but this is very important for us to send it for CD10 along with histopathology. They will just say inflammation, but CD10 will come positive. And in the same sitting, I put Mirena for her. And later, if the CD10 comes positive, if the Mirena is not put, then we can go ahead and start the OC pills, or now we put a Dino just for long term. And if we are doing a surgery for endometrioma, this is the way we go ahead and then we do the surgery, because this is what we look at from coming from lateral. Endometrioma is very common and usually seen on the right side, and posterior broad ligament and the POD is usually involved in these cases. So from lateral, when we lift it, the weakest point gives way. And once we get the weakest point, which is given way, anatomy is restored by completely separating it from the POD and the rectovaginal septum, and vasopressin is being given into the volume. And the whole, if you can see here, the cyst wall is separated with so much of ease without the need for another energy source. And we never use energy source for endometriosis. And the whole of the cyst wall just comes out without the need for any coagulation, which is needed. This is the way we remove it. And the endometriotic cyst wall is always taken out in a endobag, because we do not want scar endometriosis is what we look at. And all these cases, to prevent the further endometriosis after rectovaginal nodule is separated, we usually put the adhesion prevention thing like Intercede. This is where rectovaginal nodule is separated. This is also done in a 19-year-old kid. So this is where, when we do it, we do not wrap the tube and the ovary, and we separate it. Most of the time when we see now, we usually see adenomyoma in the rudimentary horns or septal dissection. I did not include that video here, but usually those are the types which we usually say. So what does the Foxy focus tell about the endometriotic cyst? Yes, cyst has to be during ovarian mobilization. Cyst usually drains itself in the weakest point. We were in the GCPR guidelines for this, so we made these guidelines where cyst is decompressed by suction by drainage, then content of the cyst is washed, then pitocin is injected, and by bimanual opposite traction and with an atraumatic grasper, the cyst wall is peeled off and then achieve the complete hemostasis. So laparoscopic conservative excision in refractory cases in adolescent, fertility sparing approach is essential, and avoid repeated surgery when possible is what we look at. So again, coming back to the same slide, so endometriosis management, there's a paradigm shift. Current approach has been first, whenever the girl comes, go immediate surgery and then medical management. Change over to now is three options: non-surgical diagnosis, long-term medical treatment before pregnancy or surgery, then again long-term medical management, or a non-surgical diagnosis, long-term medical management, then pregnancy and long-term medical management. Non-surgical diagnosis, long-term medical management, pregnancy, and again long-term management and surgery in the last. Again, I'm repeating this slide because I want these things to get into your brain, that once the high degree of suspicion is there, continuous combined regimen and NSAIDs, then laparoscopy when needed, and less than 16 years, it is again continuous combined regimen. More than 16, we can give GnRH agonist to confirm the diagnosis, then continue with continuous combined regimen till the girl wants to become pregnant. How the post-operative hormone acts: hypoestrogenic environment, suppression of ovulation, amenorrhea, and delay in recurrence of symptoms. This is what is called as tertiary prevention. So primary prevention is see and treat, if you can see, and then give a medical management. Secondary prevention would be by surgery or again medical management. Third, tertiary prevention is to do post-operative medical management again. It has to be multidisciplinary care. Pelvic physiotherapy also helps in the form of Kegels exercises or MCLHR. Mental health support, lifestyle modification is important. And goal of subtherapy is suppression of pain, disease progression to be suppressed, preservation, fertility. So even patients younger than 18 with persistent pelvic pain, combination hormone therapy, laparoscopic procedures should remove and destroy all the lesions, only procedures to preserve fertility, and this should be treated with medical therapy until childbearing. Complementary therapies can be given if it helps us, but ESHRE says it does not recommend. So does treatment prevent infertility and progression? The data is very limited, but natural history is a challenging issue. Whether surgical intervention changes, nobody knows, but recurrence rates with time is very high. So always treat it, and so that recurrence comes down. Long-term follow-up is what is needed, what we call it as more than 5 years. Very early diagnosis and treatment definitely will decrease the progression and infertility, and this is what is hope. ACOG says medical therapy until childbearing, suppress the pain, suppress the progression of disease, resulting infertility is also decreased. So this supports the recommendation because endometriosis is a progressive disease and long-term studies are needed. Emerging in future direction is the biomarkers and non-invasive diagnostics with only from buccal mucosa or things like that, and refined GnRH antagonist protocols. As of now, I give Reluise 40 milligrams OD for 2 years, or Dynogest 2 milligrams continue. If the patient has a depression with Dynogest, I go back to Reluise. Precision medicine and immunomodulatory therapies is what we look. So to conclude, the last slide, but not the least, is it's a debilitating disease. So even before thelarchy, we can diagnose this and start treatment. Early recognition reduces the lifelong burden, typically present with progressive dysmenorrhea and also with acyclic pelvic pain. Standard therapy, if it doesn't resolve within 3 months, then further evaluation with laparoscopy and prompt evaluation and treatment is important. Bimanual might be necessary in today's time. Good ultrasound is important, but it is important to see if there is an obstructive anomaly. Treatment can be both, but because there is no cure, long-term treatment is what we look, and it's a clinical management and multidisciplinary approach. Endometriosis is a chronic disease that requires lifelong management. Just remember that. Lifelong management is aimed at preventing recurrence. We need to remember that. Combined treatment is a step towards goal. And finally, the initiative which I'm hoping all of you will support and talk about is no POP, that is no plastics on privates. These are the reason why the EDCs have increased the incidence of endometriosis by changing the receptor level and endocrine disruption. Thank you, Dr. Mala and Oxy, for giving me this opportunity.
Yeah. Thank you so much, Dr. Manjula. That was truly insightful, a very, very informative presentation. Totally exhausting.
You told me I can take 1 hour, so I thought, okay, let me talk.
I gave you 1 hour, so you were able to complete in depth, every aspect of adolescent endometriosis. We need so much of time if you have to really cover up. You cannot just like 15 minutes or 20 minutes. So that is the reason why we wanted to do this lecture series, because it's a very, very important and always controversial and with so much of confusion as what to do when, no? So now there is so much of clarity. I'm sure it will really benefited all our delegates who have attended this talk. So now this is open to discussion. Can I have our expert Asha Rao Madam, Dr. Ramani Devi Madam, and also our chairpersons now now to take it forward for the discussion.
Good evening, Mala.
Now your
Thank
comments.
you
Yeah. Welcome,
for
madam.
asking me to be the expert.
Not
I think I've
audible.
really learned a
Not
lot of
audible.
good points today
Madam?
Not audible.
from Manjula.
Ah,
I think
Asha, yeah.
I'm there.
Yeah, I said we have learned a lot of good points, Manjula. We can write a book today on adolescent endometriosis. You have
Thank you,
covered beautifully each and every aspect of adolescent endometriosis. First of all, why does it start? We never know. There are so many theories. Is
Yes.
it
Retrograde, metaplastic, anything.
Problem with the audio, I think.
Asha,
Madam. It is genetics and
why
epigenetics which
it
worsen.
happens in some people, the retrograde?
Yes,
It's a
ma'am.
deep question. Yeah, and no, the delay in diagnosis very sad. When the child born in your hospital, she's now 16-year old. She sits in front of you and says, "I have pain every month," and the answer that she gets is, "It's okay, darling. You are a woman. Learn to bear the pain. Maybe use hot water fermentation. Take a painkiller." And this was a young doctor who went to the family doctor at the age of 16. Then again, she went at the age of 23 when she was a medical student. And again, she was told it's okay, wait for some more time, get married early. And then she joined post-graduation in gynecology. And again, she went to another doctor who saw the abdominal ultrasound picture where she saw nothing. She said, "No, it's okay. You are finishing your post-graduation, get married and have babies." And now she was sitting in front of me, married 1 year, and severe pain and grade 3 endometriosis, hematosalpinx, and she also has DIE. Many times you won't get pictures in the ultrasound because there is no chocolasis. It could be just DIE. So unless there are additions, problems, ureteric damage, hydronephrosis, sometimes you may not see this endometriosis.
Yes,
So if you
ma'am.
keep waiting for chocolasis to appear, you are too late in catching the disease. So like Manjula said, it's empirical therapy. Do not wait for the lesions to happen, a big chocolasis.
Yes, ma'am.
And we cannot be like the olden days, like the story of Mumtaz Mahal, who had 13 children by the age of 32. And my own grandmother, I think she married at 11. And by the time she was 14, I think she had a couple of abortions and 9 pregnancies and 4 children. Today's woman is very different. So I think, we have to treat them early, catch the disease early, and see that it does not progress, which is very important. So do not hesitate to give medical management to a young girl who keeps complaining of menstrual pain. And only if there is negative imaging or failure of medical therapy, one has to go in for laparoscopy and counsel them. This is a lifelong disease, because many a time, the moment a girl is better, after 3-4 months, they stop the therapy and they go to another doctor only after 2 years when there is a recurrence. So it's very important to counsel the family, counsel the girl that it's a lifelong disease. Also tell them about sometimes the need for fertility preservation, because the girl is 24 and she has bilateral small chocolate cysts and she's going to get married only at 34.
Yes, ma'am.
So it's very important that you talk to them that fertility preservation is available at your doorstep. If you want to pursue a career longer before you have pregnancies, definitely freeze your oocytes so that then you can suppress your ovaries and look for a good partner and get married at the age of 34 and have a baby at 38 with your eggs, which are about 24 years old. So I think it's very important to tell them about the need for fertility preservation and do surgery only if required, and do not hesitate to do surgery if required. Because there was a young girl who had severe pain and she was on diagnosis for more than 1.5 years. And one kidney was hydronephrotic. It had only 15% function by the time she reached us. So do not hesitate to do surgery when it's required. Very important. So thank you.
Thank you, madam. Very well told about all the points.
Yeah.
That is
Nicely summed up, madam. Very nicely summed up. One point I would like to ask Dr. Manjula. Most of these young girls, they present with all these atypical symptoms. Okay, so we seriously do not know whether they are having an early endometriosis or it is just a functional dysmenorrhea.
Yeah.
Okay, so in such a situation, how would you proceed further for these girls?
That is where the therapeutic trial comes, Mala. What is therapeutic trial? You give the medicine, and watch for the response. So you give either GnRH analog or give antagonist or continuous combined therapy also. OC pills also is fine. If the pain comes down with OC pills or with this thing, that means she is having endometriosis.
Yeah.
Then you talk to them and continue the management with Dynogest and all. There is a question which came here, which I answered in this chat box, but I want to answer for everybody else. Dr. Shrikala has asked. So somebody like Dr. Shrikala Prasad has asked, then I thought that I should tell that. So some says that because of the irreplaceable bone loss with elagolix, don't use it, is the question. So we are not going to use elagolix for long-term duration at all. Elagolix I use only for 3 months, especially Indians, bone loss is real and it is high. So, but we need a complete suppression. We want this disease to be completely suppressed, then maintained. And that is possible with elagolix or Reluise. Reluise is a very low dose and slow and does not have much effect on the bone mineral loss thing. So if you are looking at long term, then start Reluise for 1 year, 2 years, like that. But if you're looking at short term, immediately to come down, one is therapeutic trials, second is to post surgery to give it for 3 months, followed by give Dynogest as maintenance or dydrogesterone as or continuous combined regimen as maintenance, because you have to maintain maybe 10 years, maybe 12 years. Just now Dr. Asha was telling about how many years they'll have to be after the surgery also for till the pregnancy is needed. So adolescent is only before I just concentrated on less than 20 years. But like Madam said, if they once they reach 25, we should also talk about oocyte preserving techniques. Yeah. But there is a role of elagolix for 3 months for both the things.
Yeah. So, there is one controversy with the OC pills.
Yeah.
OC pills, they say like if you give it, for a longer period of time, they do not act on this ectopic endometrium. So as a result, those girls who've been on OCP for a longer period of time, they develop more of DIE.
Yes.
Yeah, so that is
I showed in a presentation, 33% of them will develop progesterone resistance, OC pills. That is, but why is it still the first line of management? Because of cost.
Yeah, cost and
easily available.
Yeah, why we are using progestins instead of OC, the natural estrogen, progesterones, is progestins have a better action compared to the natural progesterone. This problem of it not acting on this ectopic endometrium is compensated when we use the progestins. That is why we use all this Dynogest plus estrogen.
I just want to add something here. So progesterone has 4 receptors. This is for the sake of PGs or anybody who is out there. We need to understand we have a natural progesterone receptor, we have a mineralocorticoid receptor, we have a glucocorticoid receptor, and we have a testosterone receptor on which this acts. So depending on the need of the patient, we decide which progesterone to give. Medroxy is the weakest progesterone, natural progesterone, so it is not used for endometriosis. Full stop. Then you have the mineralocorticoid one, where we use drosperinone based, where we use, there is water retention and everything. That is the type of thing we need to use. Then retroprogesterone comes under the category of the newer progesterone, that is dydrogesterone and Dynogest, both come under that, which specially act very effectively on these receptors to improve the efficacy of the receptor thing and ectopic. So we use that. The desogestrel has a higher incidence of clot formation. That is the reason why COCs, especially desogestrel, are not used in endometriosis. So we need to understand where we use, how we use. Whereas levonorgestrel, that is a testosterone receptor based, is effective, but it has a lot of side effects. So orally not used, but Mirena is used, which is locally active. So we need to understand our basis, then our treatments will be very effective.
So Manjula, I have a question.
Yes,
This elagolix and relagolix have come very, very recently.
Yes,
and
ma'am.
We'll be very hesitant to start on adolescents.
Don't, because this is not, it has come to India recently, but this has been used all over the world almost more than a decade ago, because there are Aspire trials, then you have Lazarus trials, all trials which has come up. Now, I've been presenting on this topic from last 4 years when I've been on the advisory committee when the medicines were they wanted to start getting these medicines into the market. So we have read everything, seen everything. So the minute it has entered in the last 7-8 months ago, elagolix, we started off giving and we have seen. That's why I'm telling with usage, I have found that 150 BD for 3 months is the most effective way, least side effects. And if at all there are certain hot flushes in very few patients, calcium, vitamin D, and gabapentin is enough. I am not telling you all to use it for long duration at all. All the side effects in the textbooks are real. You have the side effects of clot and death with OC pills, clot and death with I pills. Still, we give it. So we need to know that is what we said with the antagonist. We have this thing to maintain the doses and how to do it individualized treatment. Now Reluise has come in the last 2-3 months. It has estrogen low dose, add back regimen is added into it, norethindrone. And the main thing is we need to understand is keeping the estrogen level at 30 to 60 so that the bone demineralization does not happen. That is there with elagolix and Reluise. Whereas when you give antagonist, it's agonist, that is not there. So now that antagonist has come, agonists have gone out of it. And you want to stop, if you are worried, you can stop that day itself. Whereas with agonists, you cannot stop.
Yeah, so again, another added advantage I would like to add is along with relagolics, see, it acts on the myometrium. So generally speaking, when you have endometriosis, you have associated adenomyosis, and in adenomyosis and all those things, they have also done a study on elastography and found that the myometrium is very rigid in case of these adenomyotic uterus.
Yeah.
So when you use relagolics, these changes occurs in the myometrium, and the pain associated with adenomyosis also comes down drastically. So that is another major advantage of this particular, the latest ones, the relagolics and other things. And along with that, they have also found now that giving the women quite a lot of vitamin D. It's very important. Vitamin D, calcium, and green tea. So this and all we've been giving empirically earlier, but then now there are also studies which are showing that these things are very important. So along with these medications, I think especially these young girls, we have to add all of these molecules also.
And there are certain questions. Dynogest, do we give continuous cyclical? We give continuously. We don't give break. Even during menstrual cycle, if they get, we do continuously. And what the specific test, except LFT, I don't do any test when we are giving the elagolix or Reluise. So like I said, the thing is, liver function should be normal.
Whether we do the LFT or not, please do renal parameters, because we don't know whether there is any silent kidney.
Already endometriosis affecting the thing. Yeah.
That's why. So urea creatinine is a must, even if you are not doing LFT, because we don't want to miss a silent kidney loss.
There's a very interesting another question, Mala, here. How long to use GnRH antagonist in adolescent? Now, I will go little away from it and tell you something. See, when we have a precocious puberty for a kid, we are giving it for 2 years, 3 years with GnRH antagonist or agonist. Why are we worried when we are giving it for endometriosis? Correct. First, our mind blocks we should get over. We can give it, if it is relagolix with add back, we can give it for 2 years. If it is elagolix, in Indians, I still feel 3 months is enough, even though they say if it is a dose of 150 milligrams OD, you can give it for 2 years or BD. But elagolix for 3 months, suppress it, change over to Dynogest, you can do that. And Reluise for 2 years, yes, till now it is about 2 years. Dynogest can be given for 10 years, 12 years, absolutely fine. The studies are there till 10 to 12 years. In my cases only, I have crossed 12 years also. So what is important is, it's a progressive disease. We need to keep the slipper in the slipper's place and not on the head. So keep the endometriosis under the feet. Don't keep it on the head and make it go till the level of kidneys and ureters getting affected. Welcome, Ramni madam.
Hello, Manjula. It was a very excellent.
Good evening. Good evening, Ramni madam. Pradeep Mitra sir also is there, joined.
Yeah, I saw Sir Mitra sir also. Okay, Manjula, it was an excellent presentation. See, I will share some of my experiences. That is, recently, last month itself, we have seen 2 young adolescent girls. One was 15, other was 20. Came with the loss of renal function.
Yes, ma'am.
Yeah, so we have to be, when you do one, and the other one is, think about endometriosis. That's what Asha madam used to say.
Yeah.
We will pick up. And as you have rightly pointed out, 8-year-old girl having endometriosis, that is genetic.
Yes,
more a genetic
genetic
reason.
and epigenetics together.
Yes, together. And another thing is, you get back into the history of the patient, they will be having history of neonatal uterine bleeding.
Yes.
That is the one reason, because at
early and
start of telarchy, you get
telarchy and early menarche is a higher risk for this, man.
For all these things.
And regarding the drug, I think oral contraceptive pills, we have to use it judiciously and better to go it for progesterone. And the right progesterone will be the dynages, because we have got a huge experience.
Yes, ma'am.
But there are people who are not tolerating dynages. I have given right from the beginning, dydrogesterone. It is an excellent drug. Dydrogesterone relieves the pain and it suppresses the ectopic endometrial tissue.
Yes, ma'am.
And you don't need to worry about the pregnancy, because even if you want to give dydrogesterone for a married woman suffering from endometriosis, start from day 5 to day 25. Retroprogesterone doesn't inhibit ovulation. It will promote fertility. So these are some of the advantages. And regarding the GnRH agonist, right, we have been using for precocious puberty for years together. I have used for a few of my patients for 5 years, 6 years.
Yes, ma'am.
Nothing happens. And similarly, antagonist, the elagolix, I prefer elagolix in a girl who's beyond 16 years because of the nature of the dose adjustment. That is very, very important. Start with 200 milligram BID if she has got severe pain, taper it and maintain it. And maybe it is indicated in patients, as you have rightly pointed out, 1/3 of the patients on dynages, they will not respond.
Yes.
Because of very high progesterone resistance. So these are the candidates who are ideal for GnRH agonists. So I think surgical indication you have clearly mentioned. Mullerian anomaly comes the most important. If we correct it, endometriosis will vanish. And then the next one is when you have not responding to pain. And one more thing is rupture of endometrioma. I have seen where the levels of
endometriotic emergencies I have written.
Yes, endometriotic emergency. And sometimes you get bowel puff also in early lesions when it is severe. So these are all some of the indications for surgery in adolescent. And one more thing is, finally, I would like to say biomarkers are going to rule the world in days to come.
I agree, madam.
See, we have done more than 600 cases biomarkers for diagnosis of endometriosis, and we have compared it with laparoscopically proven versus non-proven. Proven cases and who are not having endometriosis.
Yes,
we found certain biomarkers are very, very high, and in our place we have done it with serum.
Yeah.
Professor Deschamps has done it with the saliva. Because
Yes.
saliva is that transportation, it may be volatile, or some of the problems with the preservation of the salivary tissue, we prefer doing it with serum. And we have published 3 papers regarding that with an excellent sensitivity and specificity. So I think in patients, like I have recently done for 70 adolescent girls coming right from 13 years to 18 years, complaining of severe progressive dysmenorrhea. One more important symptom when they have is a diffuse abdominal pain. These two we have analyzed for more than 1,000 patients with endo, and we found out that progressive dysmenorrhea ranks number 1, second followed by diffuse abdominal pain. Okay. Because these girls are not sexually active, no dyspareunia, no infertility. So in these patients, when we did the biomarker testing, they were giving a very good sensitivity and specificity. And some of my patients, they Googled and they wanted to confirm endometriosis before I start the treatment.
Yes,
so few of the patients, I had to put in a scope just for the confirmation.
Yes, ma'am.
Recently,
I had one girl I put her on Dynogest, and then she was feeling very mood swings and deaf. Then I convinced them for Mirena, and she agreed for Mirena, and she's very happy now. So some Dr. Aarti, I think, asked, how do you convince a patient for Mirena? I think it should not be the first line of medication, Mirena. You can try others, and if they don't work, Mirena, because if the girl, like I said, is a rebel. If the girl is a rebel and say, I don't take medicines, I won't be on this, why should I? Mirena is ideal because it is fill it, shut it, forget it.
Yeah, okay. Like most of the patients, they have adenomyosis also.
Yes,
so especially in such patients, dynages followed by LNG IUS gives very good results. There was a question in the chat box regarding the role of biomarkers.
Yes, ma'am.
So I think
it will take time by the time it comes into India, but once it comes, the other ones.
Yeah, as such, we are trying to come out with a kit test for the biomarker. Soon it will be available in India. In research background, we are doing it.
Yes.
Okay. So And the cost is also not so much. It is only 3,000 rupees, which is much cheaper than an MRI.
And actually, then we can have less need of time to counsel the patient and convince the attendants for treatments. Otherwise, they eat our brain. Why are you putting on hormones?
Yes.
And I think I want to take this and appeal to our fraternity, who will start telling them that, why are you put on this? Who told you have endometriosis? Why? I think that should be stopped, madam, first.
Yes.
If your girl is put on a diagnosis, why? What are we gaining? We are not doing surgery. We are giving medical management. So instead of telling the doctor is wrong and endometriosis is not there because you don't have a diagnosis, please.
You don't know about it. That's the thing. Mainly, there was a study in UK where they have found out that 30% of the GPs are not aware of the endometriosis symptoms, and the patients nearly 70%. So that is one reason. And one more thing I wanted to add up is Dynagest definitely reduces the size of endometrioma also when you use it for a long term. But we cannot say it for everybody.
Yeah, it's only 20-30% reduction.
Yeah, they're very happy.
Yes, ma'am.
But another point what I would like to make is like we should not delay in surgery also. See, you have a huge.
Asha madam told when you need, you should do.
You have to operate when it is needed.
Not hesitate to operate.
Yes, agreed.
Really think because she's adolescent and she's got a huge endometrioma, we are going to do damage by reducing the reserve. But then it is other way around, no? If you are going to leave behind also, it is going to reduce the reserve. So that is one point I think for our juniors, we have to really get very clear and
so we should draw a clear line when to operate and when to go for medical management. That's the
take home message.
Yeah. So I think it was a very good
discussion.
Informative, and also we had a great discussion. Anything else anyone would like to ask?
Only one question. Can we do it in menstrual blood, madam, the biomarkers?
Yeah, there are certain biomarkers that can be done in menstrual blood also. But why to go for the menstrual blood? You have a serum thing is available.
Let me tell you one thing, Vijaya madam. Controversy about menstrual blood is that automatically the CO125 will be little high in that. Everything automatically will be high. So it is always it is like, non-specific. But specificity will be increased if it is done in the serum.
Yeah, and also whether the patient will be willing to collect the menstrual blood and give it to that is little cumbersome, no?
Anyway, they have a menstrual cup.
Now, still not many would be comfortable, especially adolescent girls. We cannot, convince them to do it. So I think Dynagest again, madam, as an OCP, it is also very good because that is the irony, like we know it is a progressive disease, hyperestrogenic, but still we are giving pills with estrogen. So that is one question which it runs in everybody's mind. Why are we giving estrogen when it is a hyperestrogenic condition? That answer to that, what I have this thing is like it is because some amount of estrogen is always necessary for the progesterone to act because the progesterone resistance condition. So that is the reason why
one more is that the dose which we give is only 1 milligram and not very 1 microgram. And as add back may come dose dete, and it is a priming. Estrogen priming is necessary for the receptor to act. Otherwise it won't act. That's it. Full stop.
That is only the reason why. So that is one thing which runs in everyone's mind, and I think we should be aware of it. So I think we have covered all aspects. Surgery, medical, diagnosis also, the delay in diagnosis, only if there is a suspicion, put them on OCPs and see whether they are responding, and of course everything is fine. Okay, I think.
Can I go, Mala?
Madam, I will relieve.
You can continue. Okay.
Okay, right.
Wonderful session. I congratulate you, Mala, for having brought this session.
Yeah,
done by Dr. Manjula.
Thank you, madam.
Yeah, thank you so much, Dr. Manjula, for a very, very informative and very exhaustive presentation. In fact, more than the presentation, the discussion aspect also was extremely good. So we all know how the young girls really suffer because of this particular disease, and now we are able to give a solution to all of them if we are able to understand the disease and treat them in the right manner. So I would like to thank Ramani madam, my co-convener, and also also our expert, Dr. Asha Rao Madam, and our chairperson, Dr. Vijay Madam, and Dr. Victoria, for joining the session and making this session very, very informative and also interactive. Thanks a ton, Dr. Manjula Anagani, for all your time and your valuable informations. And thank you, Oxy. And I will also extend my heartfelt thanks to Endometriosis Society India for joining hands with Oxy for doing this webinar. So we are planning to continue this every month on some important topic. All the aspects of endometriosis would be covered in an exhaustive manner like this, with some eminent speaker on that particular field. So thank you so much, and also thanks Shield Pharma for this platform and for the academic support. Thank you, Sahiti, for a seamless transmission. Thank you.
Thank you. Mala, mention to them about the starting of the Endo Society of India Tamil Nadu chapter.
Yeah. So
so we'll be starting it probably in the month of March, which is the Endo Awareness Month. And I request all the members to become the members of Endo Society of India with a very nominal and lifetime
membership.
Membership about only for 5,000 rupees.
People are also aware of this society, madam. So actually, there is a society for endometriosis called the Endometriosis Society India, where Dr. Mahapatra and Dr. Pradeep Mitra are the president and secretary. So we are doing this program along with them just to create awareness about the society also. And we are planning to start a Tamil Nadu chapter so in March. We want more and more members to get enrolled in this society, and also as we start the chapter, we'll also want to have more members in our chapter as well. So currently, to start with, we want many to enroll in the Endometriosis Society India and become a member, so that over a period of time, in another 2 or 3 months, once we have a lot more clarity, as we form the chapter, we will enroll everyone into the Tamil Nadu chapter. So this is for information for everybody. We'll slowly share this message to everyone as well. Okay, madam.
Okay. Thank you.
Thank you.
Thank you so much.
Thank you, ma'am. Thank you, everyone. So thank you, Pradeep Mitra sir, for joining us. Okay. Thank you, all the delegates. See you all in the next webinar. Bye.